So the primary problem in the underserved communities is the affordability, access, and quality of care. And so those are the three things that we're trying to address. And so right now, the devices themselves are not affordable. Even the handheld meter, glucose meter, they'll give them the meter and strips for the first month. Then when the strips run out, they don't buy the strips. And so even those are too expensive at $30 a month or whatever. So that's affordability. Access is the other one that we're trying to address, and that's just in a rural area, getting to a hospital is challenging. And then when they get there, do they really need to be there? If you're diabetic and your blood sugar is low, you could take juice at home and not have to go to the emergency room if you could monitor that. And so the access to care. And then the third thing is the overall quality of life. And so you will feel better, you will have less amputees. In Texas, we always think rural, underserved. South Texas obviously is a good example of that. But when you start looking at the partner schools, Rice, UCLA, and Florida International, they're very urban. And the urban underserved is a big issue as well. It's slightly different, but when you think of lack of access, you think of long distances to travel. But for instance, in UCLA, there's an area, the Compton area, where they have a lot of underserved, and it's about a 30-mile radius bounded by 3 highways. And if you're in the center of that and you don't have transportation, because a lot of people in the city don't, and you get sick, you have to get on a bus, and then you're infecting a bunch of other people, and then take it to the clinic, which is outside this bounded highway area. And so it's still underserved, even though you're in the middle of a huge city, and you wouldn't think it would be underserved, but it is. In the past, I think we've had a bunch of really good engineers developing really cool technologies without any idea of how those technologies would work in the underserved communities. And part of this impetus came out of our team, Rebecca Richards-Cordham at Rice and myself. We've been to Africa, we've been to South Texas, and some of the team has been to South Texas, and it's the same thing there, actually, quite frankly, as the underserved communities is you can't just throw technologies. What works in the U.S. in a hospital may not work in the underserved community, or may not work in Rwanda in their clinics. So getting there and really getting on the ground, boots on the ground, what is actually going to work for that community is really key.